And as a result, we began setting some standards, saying to companies, you know, if you're going to provide a home care benefit, it has to be a benefit that people understand as home care, and prohibiting certain practices like requiring a prior hospital stay before a nursing home benefit would be payable. We've had some consumer protections that have been incorporated into the law, and we have some requirements for agent training so that the agents know clearly what those policies do and what they don't do, and can explain them to the consumers that they're selling them to. Then we had some legislation to try to deal with what began happening with premium increases. And we actually have had several rounds of premiums increasing, but not to the extent that they did beginning in about 2010, where rates just went off the charts for a lot of people, and they ended up, some people getting an average of 40%, but some of the older policies in force at the time getting rate increases of 92%. Which for an older person, somebody who's in their late 70s, 80s, and living on Social Security fixed income, an increase of that magnitude was really horrendous for people, and they had to make some pretty serious decisions about how to deal with that. We continue to move through the regulatory process of rate increases on business that's been written in the past, because the insurance industry is learning, just as consumers are learning and just as you as legislators are learning about the costs of long-term care, how they occur, how many people it will happen to, what kinds of services they need, how long they'll need them. All of that is evolving in the insurance industry as well as in the consumer community. So we had a perfect storm for rate increases. We have about 8 million policies in force across the country, which is a very small number. And those policies are spread across dozens of companies. And within each company, they have many different risk pools. So in looking at, you know, this in either a national perspective or a state perspective is a really inefficient way to ensure the cost of this kind of care if that's the only vehicle you have for financing it. Companies learned through the claims process that their expected assumptions were different than the actual assumptions. They had many fewer lapses than they had predicted. They had greater morbidity, more claims than they predicted, and particularly for dementias, because the claims now are about 50% for dementia, where in the past that has not been true. It's been functional disabilities that have caused claims. And there are more claims for home care because there are home care benefits within these policies. So people often trigger those benefits long before they will trigger an institutional benefit for assisted living or for nursing home care. Nursing home care is absolutely the last step for anyone. Nobody's going to a nursing home if they have any other option. So these other benefits then are more important. And then, of course, we all know what happened in 2008 with investments, and companies haven't been able to earn the percentage of income that they had predicted on their reserves. And they have statutory requirements for reserves based on the number of policyholders they have and other factors. So as a reaction to that, which in my work in this field was about the third time that there have been dramatic rate increases on long-term care policies, companies began to pull back. Some withdrew from the market entirely. Others repriced and narrowed the benefits of the newer policies that they were selling. And they began doing what's called gender rating. So women pay much higher premiums for their coverage than they had in the past when men and women had similar premiums. And so women, many women are being priced out of the market on the basis of gender pricing. And that's because the industry learned through their claims that women not only live longer than men, more women were buying long-term care insurance, more women filed claims, and the claims lasted longer for women. And part of the reason for that is not just that women live longer, but they tend to live longer alone after their spouse has died. And that means they don't have that live-in caregiver that's so critical to being able to stay at home. So more women will wind up in institutional care given those factors. The other thing that's true about this that I think is important is that women shield men from some of these claims because they're the live-in caregiver. And so the men tend to have claims later in their disability because they are more likely to have that live-in caregiver. So their claims appear not to start as early, not to be as long because of those factors. Then there is more restrictive underwriting going on today. Companies are doing cognitive screens now, actively screening for cognitive problems on an application. They're doing paramedical exams, they're doing lab tests, and one company in particular is now gathering health history on the applicant's parents, looking for early onset of chronic disorders that might mean that that applicant would have a claim in the future. Some companies have added long-term care benefits to life insurance and to annuities, and I often characterize that by saying if you take two really complicated products and you put them together, there's even less likelihood that people are going to understand what they're buying and how those benefits are going to come out of what is an eventual death benefit, or would be. So there are a lot of those newer products on the market that present their own problems with consumer protections and consumer understanding. And even agents who are selling them often don't know any more than what the company has told them about that particular product. So agents may not be as informed on a combination product like that as they might be on a long-term care insurance policy that they're required to have certain training in order to sell those products. I put this chart in because I want you to see the difference between people who bought these policies in 1990 on the far right and people who bought them in 2010. This study is done every 5 years, and there's a dramatic difference in the buyer market. You can see that the characteristics of people buying these products in 2010 is very different. They're younger, they're better educated, they have far more income and assets, and they're more likely to be connected to employment in one way or another. That's very different than the way this product was in 1990 when people saw it being sold to middle-income people. This chart shows that the market has shifted to higher-income people, those with less potential for spending down to Medi-Cal, and people who have much higher net worth. So that's why I put that chart in there so you could see that difference. And here, you know, boomers are not like their parents. Boomers have changed every institution they've moved through. They will change long-term care in some way that we don't yet know. But if you look at them in comparison to their parents, they're less likely to have the savings and assets their parents had, less likely to own a home, they're less healthy at younger ages, they're more likely to have been divorced, which may mean there may not be a live-in caregiver for those boomers. They've had far fewer children than their parents have, and that's a caregiver issue because they may not have the children available to them to help them in the early stages of their disability. And cultural differences may very well influence whether people buy an insurance product or not, or how they organize care, whether they pay for care or not. So there are a lot of differences in the boomer population than the populations that we think of today as being the market for long-term care insurance. Also, boomers are going to have a very big effect on the economy, which a lot of people are not looking at, because their savings rates will fall and they will begin using savings at some point. There's going to be a shift in products and services. There already has been, if you think about how medical care and medical services and medical supplies and prescription drugs have all escalated with people becoming older and living longer. And there are going to be employment gaps as well in skilled trades because of the concentration we put on college now rather than on trades. So there are a lot of changes coming, both in the types of people who will need care as different from today, and in the economy as that population becomes older. There's a statistic that's often used nationally. 10,000 people a day turn 65. Now, that's a staggering number. 10,000 people a day across this country turn 65. And that will be true every single day for the next 17 years. And California has a portion of that population. So when people talk about planning to pay for long-term care, how do you plan to pay for something that you can't buy the insurance, either because you can't afford it or because you already have a condition that will exclude you? Or what else do you do? Can you save? Yes, you can. Can you save enough? Do you have a long enough time to save it? So people don't actually have a way to plan for care now. This is just a number of things that have happened at the federal government level. We had the tax qualified policies beginning in 1996. The federal government's funded the marketing campaign of Own Your Own Future. There's a federal long-term care program for the federal family. They expanded the partnership option to all of the states. You all know that the Class Act was repealed and that there was a long-term care commission, as Bruce Chernoff talked about, that actually ended up with 2 reports to Congress, a majority report and a minority report. And then there has been nothing else happening at the federal level on financing long-term care since the mid to late 80s during the Pepper Commission. Which is about the time that I got involved in this, actually earlier. And I would have assumed back in the 80s that the federal government would have come up with some kind of a solution or a program by now. On the state level, we've ended up in the state chasing long-term care insurance issues as the product has evolved and families complain to the legislature and laws are passed to make the product better or to put in consumer protections or other pieces of that. But there is an increasing awareness of long-term care and costs. The California Partnership grew out of that. CalPERS has its self-insured program. There's a state income tax deduction for tax-qualified policies, and there have been a variety of improvements to long-term care services and supports for people who are poor or who are going to be poor in the future. But there hasn't been anything done for that middle income level of consumers to help them figure out how to plan and pay for this kind of care. It can't be one simple solution. It can't be just insurance. It can't just be Medicaid. It's got to be some combination of things that come together in a coordinated way. Relying on insurance means relying on an inefficient system. They have too many insured pools of various sizes, uneven distribution. Some companies sell to high net worth clientele who make their investments through a certain company. The marketing, sales, and distribution costs add to the price. Profit margins are driven by Wall Street, and that adds cost to the product. And too many who need future care can't buy it at any price, either because they're already ill, they can't afford it, and women in particular who are being screened out because of costs. So too many middle-income people have no way to plan for this kind of care. And the instability of the premiums is frightening to a lot of people, and I get adult children coming to me often with something from their parents, and they're being exposed to what's happening to their parents with these insurance policies, and that then prejudices them against doing anything with insurance. There are some future possibilities. There are some things the state could do. You could design some kind of a program where you wrap either public benefits around private benefits or private benefits around public benefits. You could create some sort of a mandated subsidized insurance benefit package so that people would have the assurance of having a standard package of benefits that then could be used either as an insurance product with the public benefits at the back end, or it could be something where you have an enhanced Medicaid program, so you have some sliding scale premiums, you have some way to combine both the public and the private sector. That you could do tax credits for premiums. For people who don't pay taxes, you could do refundable tax credits. That actually subsidizes the premium in that way. You could subsidize premiums based on income and assets. You could provide stop loss coverage. There are a number of ways that you could think about doing things that combine the public and the private sector. But I would want to be sure that whatever you came up with had the consumer perspective in mind, so that we don't go through another round of evolution of products and programs where we have to address all of the issues that come up during that evolutionary process. So with that, this is another slide talking about the comprehensive approach. And one of the things that I would want you to pay careful attention to is that geriatric care management can be the key to whether somebody can organize care in a way that a person can stay at home in a fiscally sound way. People who know what they're doing with long-term care can often keep someone at home far longer than they would be able to do on their own, or the family would be able to do, because they know the services in their community. There's a lot of electronic capability now that hasn't been there in the past. We can put GPS in clothes that people wear, in shoes. You can track wanderers with GPS. You can use sensors in a lot of different ways on appliances, doors, so that you can monitor somebody from a distance. You can do residence monitoring with cameras so that an adult child can continue to work because they're able to check in and see what's going on with that person. And, my goal would be to construct some kind of a comprehensive system that combines a lot of these newer technologies with public and private funding, and in ways that allow adult kids who are doing the caregiving to continue to work and still be a caregiver when a formal caregiver or these other options are not available. This is our contact information, and I'd be happy to answer any questions that you have.
And we only have a few minutes for questions to stay on the chairwoman's calendar here.
I just want to say that, first of all, I really appreciate the presentation, and certainly we have to look at some ways to address this growing need, because as you have indicated, 10,000 people are becoming seniors every day. Mm-hmm. And so we certainly need to provide a benefit to them. I'm particularly interested in the dynamic that you created and talked about in terms of the private partnership, public partnership in terms of some actual care based on someone receiving Medi-Cal, Medicaid, and then still having some services provided for them, especially when the time they need it. So if you have anything else regarding that, I would be interested in terms of looking at that and examining something like that.
All right. I don't have anything with me today. I'd be happy to talk with you or your staff about that.
I would love that.
Okay.
That'd be great. Thank you.
Ma'am, you mentioned some people are not getting covered due to pre-existing conditions. Mm-hmm. Can you explain a little more on that?
Sure. The insurance industry does health underwriting before they will issue a policy. So they go through a lot of screening now before they will issue a policy to someone. So even if they can afford it, they may not be able to get it because of their health or the health of their parents, or some information that's in their medical records. So the companies. This is something I think it's important to understand. Insurance companies are profit-making. It's a profit-making industry. They have to make a profit on the products that they sell. So they are selective in who they issue products to. Just as they're selective with auto insurance, they're selective when it comes to long-term care insurance, and as they used to be with health.
Okay.
Thank you very much, Mr. Chair. And so you just raised another interesting point. It used to be where you cannot deny someone because of pre-existing conditions. And so now we find ourselves where we have, I guess in your words, insurance companies that's denying coverage, even though that a person can afford it, but they still may not qualify under certain rules. Mm-hmm. And so how widespread is that? And do you also see, another part to my question, do you also see that the baby boomers who are providing and actually getting this insurance is because, are you seeing, I think you're seeing a spike in terms of the baby boomers actually getting this kinds of insurance. And is that because of what particular reason?
There isn't a spike in people getting this kind of insurance. If anything, it's a dramatic fall off from getting this insurance. And in part, that's because of the cost. And in part, that's because some people won't qualify for coverage because of their health or their prospective health, because they're being screened out at the very beginning.
Those individuals are because of the age and possibly because of precondition. But what about the baby boomers who, are you saying that they don't get it because of what?
Well, I don't know that I'd say baby boomers specifically.
Okay. Because
when you're looking at insurance, you're looking at a market. You're looking at, a total ages from now about 50 to about 75 is the market for long-term care insurance for most companies. And so they're not looking specifically at baby boomers, but what they are looking at is when you apply for coverage, how likely is it that you're going to need it and need it right away? People would be screened out through the health underwriting and through their health screening. So they wouldn't even accept somebody who had a health history that would lead to needing long-term care.
Interesting. Okay.
Ms. Burns, thank you very much.
Thank you.
And next up we have Dr. Ronald Redfoot from the AARP.
Now, how do we get out of this? How do we get my... I am going to use mine, yes, and so it's loaded onto these.
Are you already loaded?
Yeah,
Okay. So,
there it is, right there.
all right.
Okay,
Do you know how to use these?
yeah,
Okay.
all right, thank you. And let's see here, let's get teed up here, and, well, okay, come on now. Okay. Okay, there we go. All right. Well, thank you all. And I thank you all for this invitation. I have to say in beginning to comment on the fact that you have 3 committees who are collaborating here in gathering information and preparing and thinking about the future. I commend you for doing that, and all of you here today. I appreciate your inviting me to be a part of this. I want to begin, again, my name is Don Redfoot. I'm a Senior Strategic Policy Advisor working with AARP's Public Policy Institute in Washington, D.C. I want to start, though, by commenting again on the issue about what is long-term care or long-term services and supports, and recognizing that this is not just an issue for the older population that we have concentrated on heretofore. Roughly 60% of those who need long-term services and supports are over the age of 65, but 40% are not. 40% are younger people, and these can be. And so when we're talking about long-term services and supports, we're really talking about what it is that enables people to live a life with a disability at whatever. And that can mean a variety of ages. At all ages, disability can strike. It means all kinds of sources of that disability, from chronic conditions, conditions from birth, accidental injuries. It occurs to people at all economic levels with various types of resources in different kinds of family structures. And so this is an important issue for all of us. It is not a Republican issue or a Democratic issue. It is an issue that affects all families, and so, and at all ages and with all types. So it's an important issue, and I commend you all for the work that you're doing to address it. I'm going to have a few comments to frame some of the important tools that I think will be useful to the committees here represented as you think about the various options, some of which were described today by the earlier speakers. But how do we have the tools? How do we get a handle on this enormous issue that has so many different aspects to it? For long-term services and supports aren't just the paid services. It's the housing that you live in. It's the support of the families that are involved. It is the health care component. It is the personal care services. So yeah, all of this makes it an incredibly complicated topic, an complicated issue to address, but one that is all the more important for that complexity. I do want to start by talking about the long-term services and supports state scorecard. This was a collaborative effort that report issued by AARP, but in collaboration and with funding from the SCAN Foundation that Dr. Chernoff represented here today, and the Commonwealth Fund. I commend to you this report. Unfortunately, in giving you the link, I gave you it's longtermscorecard.org, and so I will note that. This scorecard is an important a tool for evaluating the performance of states and comparing state performance on a number of variables within 5 different domains of performance that you see listed here. The first being affordability and access, the second choice of setting and provider, a consumer choice element, the third, the quality of life and quality of care, the fourth, support for family caregivers, and a fifth that we added to this time in this wave on effective transitions, noting that those who need long-term services and supports are also often frequent users of healthcare services and other services. And so how effective are we at making those transitions between those service systems? Today, I'm only, well, I'll just note that overall, California came out pretty well. It is in the top quartile, number 9 in the country. But I also want to note, in looking specifically at the affordability and access, since we're talking about financing here today, that there are many domains within that, many different ways or indices of that one domain of affordability, including the affordability of private pay services, those who have the private insurance that Ms. Burns talked about, the reach of the Medicaid safety net, and then the ease of navigating the system. And here are some of the measures. And so while California comes off pretty well overall, and especially on its Medicaid measures, you will see that it varies on some of the other dimensions in terms of the affordability dimensions, the coverage of private insurance, and especially the aging disabled resource centers and I will honestly tell you, I'm not sure why California is 49, but this might be something to find out in terms of. I would also note that while I don't need to tell the committees here today that while California stacks up pretty well on the Medicaid, this is on historical data, and your recent issues with respect to Medicaid funding of long-term services and supports shows that maintaining that high status is not necessarily an easy job, especially given the strong history that California has had in promoting consumer-directed services through the in-home services program, as well as your adult day center program. But of course, these are not to be taken for granted, and indeed, I know the problems of financing that you've had, but I hope that you will not lose your proud standing on the Medicaid issues here. I do want to talk for a moment, while we're primarily looking at financing, I do want to talk about family caregiving because it is an important element of financing, and it has important financial consequences, in part because the vast majority of providing services comes from family caregivers,